Hello everyone, I'm Dr. Juliet Tchorbajian, and I'd like to present to you today what prosthodontics is and why it is unique. Have you ever met a structural engineer, a sculptor, a quarterback, a doctor, a crime scene investigator, or a material scientist? Have you ever met someone who is all these things and did not have the last name Da Vinci? Well, meet the prosthodontist. Prosthodontists are a rare breed, in fact making up less than 2% of all dentists. Prosthodontists are one of the 12 dental specialties recognized by the ADA. This fascinating dental specialty concentrates on unearthing and deeply understanding the root of the most complex dental problems, and designing a treatment plan that not only looks great, but restores oral function and health of the patient. The official definition of a prosthodontist is long, but the most important thing to understand is that the prosthodontist has been trained to analytically hone in on the true cause of the patient's clinical concerns. The prosthodontist follows a rigorous methodology that goes far beyond see a cavity and fill it. The analysis looks more like the following. We start with data collection. This includes the patient interview, in which as much as possible is gleaned from the patient, both explicitly said and implied. In addition to asking about their medical history, it is crucial to understand their diet, their social habits, and even relationship statuses, amongst many other details. Combining this anecdotal information with technical documentation, x-rays, diagnostic casts, photographs, provides us with as complete as possible picture of the environmental variables that have led to the current visit to our dental chair. After collecting all this data, a diagnosis is formed, and equally importantly, the etiologies are identified. Then after all this is collected, a treatment plan can be formed. Prosthodontists focus on etiology because etiology is a study of causation or origination, or as defined by the Glossary of Prosthodontic Terms, 9th edition, the factors implicated in the cause or origin of a disease or disorder. The word is derived from the Greek etiologia, giving a reason for. More completely, etiology is the study of the causes, origins, or reasons behind the way that things are, or the way they function. This is one of the hallmarks of a great prosthodontist. Some diagnoses can be made simply by visual inspection, for example, edentalism. But to understand the reason that the teeth are missing will critically inform the next steps in the prosthodontist's game plan, which is treatment planning. There may be many possible treatment plans with an even greater range of outcomes and consequences. Understanding the diagnosis and etiology helps us make an informed set of recommendations to the patient to ensure they have the best possible information to proceed with a certain treatment. Speaking of treatments, prosthodontists rely heavily on advanced materials with unique properties and specialized applications. The forces and stresses present in the mouth are staggering, with a second molar able to produce over a kilonewton of force. It is up to the prosthodontist to utilize their extensive knowledge of materials down to the crystalline structural level, and strong background in geometry and essentially structural engineering, to develop and successfully fit a treatment to a patient. And don't forget that it has to look great, feel great, and not negatively impact their speech, and last for many, many years to come. Prosthodontists are trained in light and color theory. How many different light sources must you use when looking at a final crown to ensure its color accuracy? Also, we use 3D printing, and most importantly, photography is one of the most important things. The list goes on and on. Now that I've introduced this wonderful field, I'd like to present a case study which illustrates what a typical day at the prosthodontist's office may look like. This case is a full mouth rehabilitation case of a gummy smile. The patient AW is a 50-year-old female who's an executive secretary. She's married and has one daughter, and both her husband and daughter were involved in aesthetics and came to the first appointment. The patient's chief complaint was, "I feel like something is not right in my mouth, even though my other dentist said I'm okay." The patient also stated she is not happy with her smile and that she could see grayness around her crowns. The patient has non-contributory medical history and no medical alerts. She denies tobacco usage, alcohol usage, and substance abuse at any point in her life. Her dental history is long and complex, but she has had a history of oral surgery, restorative work, fixed partial dental work, root canal therapy, periodontal work, removable partial dentures, and even implants. And despite all this, the patient stated during her patient interview that she is still experiencing pain and discomfort. She said she has noticed drifting of her teeth. She stated her gums bleed when she brushes. She does have difficulty chewing because of the lack of posterior support. She is sensitive to hot, cold, sweets, and pressure. She doesn't feel like she grinds her teeth. She doesn't feel that she has dry or burning sensation in her mouth. She's not satisfied with her dental appearance, and her concerns was that she's had so much dental work in the past and she was never satisfied with her appearance and things never felt right. She wanted to express that to me, that she wants to make sure that this time along she's more involved with her treatment. For the patient interview, she had emotional concerns, and they were her discomfort, her embarrassment, and time, and her emotional motivators were her aesthetics, health, discomfort, and status. During the patient's head and neck exam, her lymph nodes, lips, neck, face, tongue, buccal mucosa, pharynx, and soft palate were within normal limits. She had no swelling, no lymphadenopathy, no asymmetry. She had a blood blister on the lower right ridge from trauma, and she had a fistula over number 19 implant site. For the patient's diet, for breakfast she has coffee, for lunch she has coffee, salad with cranberries, dinner she has fish and rice, and for snacks she has coffee with fruits and nuts and candy. It's important to note that the patient drinks a lot of coffee, and we're going to see in the next few images that she has a lot of staining on her crowns. And it's also important for us to educate her when she gets her new final restorations and during the provisional phase how coffee can very much stain them. Also, the patient, after many questions, again, as prosthodontists, we're supposed to be investigators, she finally admitted to eating gummy bears, and that has a very high sucrose and fructose concentration, and it was very important that we address that from the beginning before even touching this patient and doing any restorations on her. So the patient understood that she had to have modifications made to her diet. According to the caries management by risk assessment, and after looking at all the radiographs, you're going to see that the patient is high risk, and she was placed on the Featherstone protocol. Here is a photograph of the patient's intraoral cavity and maximum intercuspal position, and we can see that she actually has a restoration on every single tooth, and we can see the edentulous spaces in the patient's mandible. Also, we can see the recession and the grayness around the crown margins that the patient was referencing in her chief complaint. Here is the patient's maxillary occlusal view, and we can see the significant staining on her crowns from the coffee. We can also see the patient had restorative work done on every single tooth again. We can see there's porcelain fracture, the crowns are splinted, and we could see some sort of a retreatment through the crown on tooth number 3. This is a photograph of the patient's mandibular occlusal view, and we can see the edentulous spaces on the right and left side. We could see on number 31 site the patient has a blood blister, and on site number 19 the patient has the fistula. We can also see the restorations and the caries present, and we're going to look further in detail in the next slides. For the findings, the maxillary right posterior sextant, we can see number 1 is missing, number 2 has an occlusal composite, staining, and bone loss, number 3 is a PFM crown, cast post and core, root canal therapy, retreatment, and we can see the access hole through the crown, mesial caries clinically, bone loss, and staining. Number 4 is a PFM pontic with buccal bone loss. Number 5 is a PFM pontic with buccal bone loss and occlusal wear. Number 6 is a PFM crown with a cast post, root canal therapy, mesial, buccal, and distal caries with bone loss radiographically. Number 7 is a PFM crown, cast post and core, root canal therapy, mesial, buccal, and distal caries, a PAR, and bone loss radiographically. Number 8 is a PFM crown, cast post and core, root canal therapy, apicoectomy, mesial and distal caries, bone loss, and a poor crown to root ratio. Number 9 is a PFM crown, cast post and core, root canal therapy, mesial and distal caries, and bone loss radiographically, and a poor crown to root ratio. Number 10 is a PFM crown, cast post and core, root canal therapy, gross mesial and distal caries, and bone loss. Number 11 is a PFM crown, cast post and core, root canal therapy, mesial and distal caries, and bone loss. Number 12 and 13 are PFM pontics with buccal bone loss, and we can see sinus pneumatization that's irregular in their x-ray. Number 14 is a PFM crown with cast post and core, root canal therapy, Mesial buccal and distal caries and radiographic bone loss, and number 15 and 16 are missing. Number 17 is missing. Number 18 is a mesially tilted tooth with buccal caries and an occlusal composite. Number 19 is an implant with a fistula, and number 20 is missing. Number 21, there's an implant there. Number 22 through 27 all have PFM crowns, cast posting cores, root canal therapy, mesial and distal caries with bone loss. On number 22 and 27, we can see the RPD distal rest seats filled with composite, and number 23 is missing. Number 28 is an implant that has distal bone loss. Number 29 is missing, 30 is missing, 31 has trauma from eating a hard cracker. We can see the blood blister, but it's missing, and 32 is missing. For the anatomic considerations, there has been appreciable resorption of alveolar bone. The sinuses have pneumatized, there's no redundant tissue, and this patient does exhibit uncontrolled caries. As we can see here in this x-ray, the patient has pneumatization of her sinuses, and we can see on the right, the patient has an irregular sinus floor, and those are the most difficult types of sinuses to treat during sinus floor elevation. So that was just important to note when coming up with a treatment plan. When the patient presented to clinic, she was only wearing a fixed partial denture, and the age of the prosthesis was 10 years old. The prosthesis is not serviceable, was not retentive, did not provide occlusal landmarks that were acceptable, the aesthetics were not acceptable, and the patient does have an accurate self-assessment of the prosthesis. The patient does have realistic assessment of her prosthesis and understands a new prosthesis would need to be fabricated. For the patient's diagnostic occlusal evaluation, her vertical dimension of occlusion was acceptable, her freeway space was 3 millimeters, and the plane of occlusion was unacceptable. A therapeutic wax-up was done, and the vertical dimension was increased by 1 millimeter, the treatment position was in centric relation, and the occlusal scheme is anterior guidance. Splint therapy will not be required for this patient, and the reason for the wax-up was for a mock-up for a new CBCT and to plan for implant placement. For the smile analysis, it was important to look at the patient in repose, smile, and full smile. The patient mentioned during the first visit that she sees the grayness around her front crowns, and she did not like that. As we can see, this patient is classified as having a gummy smile. The patient was shy at her initial visit and didn't want to smile that much, but I caught a glimpse of her actual smile when I made an intentional joke in the clinic. Again, it's our job to be crime scene investigators to make sure we gather all the information before starting treatment. Once the patient got comfortable with me, she showed me her true smile, and I took multiple measurements with multiple pictures, as you can see here. It is important for us to get measurements to really evaluate how much tissue the patient shows when smiling. She wants to know her options of eliminating her gummy smile, so in my mind, I was reviewing what would be possible treatment plans for this patient. I discussed with her the treatment plan will be finalized once the prognosis was determined for her teeth. For the aesthetic analysis, we can see the different zenith positions, and we can also evaluate the patient's plane of occlusion. We can see the anterior maxillary teeth are below the line relative to the canines and the posterior teeth. It is also important for us to look at the diagnosis and etiology, as we had mentioned before. She has recurrent caries, and it could be because of her poor oral hygiene, diet, bacterial plaque and byproducts, host response, lack of consistent dental care, patient neglect, and inadequate restorations. She was diagnosed with generalized mild chronic periodontitis, and this could be because of the patient neglect, poor oral hygiene, bacterial plaque and byproducts, host response, and lack of consistent dental care. Her partial edentulosum could be attributed to the bacterial plaque and byproducts, poor oral hygiene, caries, patient neglect, and iatrogenic. Abrasion could be from toothbrush and mechanical wear. Her periimplantitis can be from bacterial plaque, her oral hygiene instructions, and iatrogenic. And the unacceptable plane of occlusion could be from tooth loss, patient neglect, lack of consistent dental care, iatrogenic, and teeth drifting. When looking at the prognosis of the case, we saw that many of the teeth were questionable, and the restorations would need to be removed for us to see the underlying tooth structure. The patient agreed and signed a tentative treatment plan, and understood that once her restorations were removed, the treatment plan would be finalized. The patient was informed of all possibilities before agreeing to remove her crowns. Once the crowns were removed, x-rays were taken, and the teeth were evaluated. There was deep recurrent decay on all the teeth except tooth number 2. The posts were loose and the caries reached way down into the roots. The patient understood that the prognosis of the teeth were all deemed hopeless. Once that was done, we went to finalize a treatment plan. A new maxillary impression was taken for wax rims to be fabricated to determine the restorative space the patient had. We took a new CBCT with a guide to evaluate her lip line position with her available bone. The bony platform should be reduced so that it is at least 4 mm below the position of the lip during maximum smile to ensure concealment. Of course, this radiograph needs to be done to see if this is possible. The implants can then be placed at this level so that the prosthesis tissue junction is not visible during maximum smile. To accurately reduce bone to a level below the position of the patient's smile line, the patient's clinical maximum smile must be transferred to a clear radiographic smile guide by using a cone beam computed tomography scan. This device allows the clinician to actively plan the amount of reduction and the position of the implant. The treatment plan consisted of removing the maxillary teeth that were hopeless and maintaining the 2 canines for a fixed prosthesis during healing of her maxillary bilateral sinus lift. Once she healed from the maxillary bilateral sinus lift, the remaining 2 teeth would be extracted and implants would be placed with immediate loading. For the mandible, all the teeth were also deemed hopeless and the 3 implants were mobile and the patient was symptomatic. So during that appointment, same visit, we would extract all the teeth, explant the 3 implants, and immediately place implants and load with an immediate provisional. The patient's final prosthesis would be a monolithic full-arch zirconia prosthesis with anterior cutback. Also, there were many in-depth conversations with the patient about her alternative treatment plans. If immediate loading couldn't be done, the patient would be sent home with immediate dentures that were fabricated beforehand. Also, the option of maxillary zygomatic implants was reviewed with the patient, maxillary overdenture, mandibular overdenture, and even a maxillary CD and mandibular CD. Now let's discuss the progress of this case. The patient had bilateral sinus lifts with BioOS. The patient was given an interim prosthesis that was fixed on the 2 canine abutments that were maintained. A dual scan CBCT with radiographic markers was taken for this patient. And as you can see, this was all done to plan for implant placement. In this scan, you can see the bilateral sinus lifts that were done, and the depth of the implants and position of the implants were all determined before the surgery. Using the initial scan, we had determined the appropriate placement and depth of the implants to hide the implant prosthesis junction despite this patient's high smile line. And we saw that the patient would still have available bone after removing 6 mm of bone. So when working with the surgeon and the prosthodontist, we decided that 6 implants would be appropriate for the maxilla for a fixed final prosthesis. In the mandible, we determined that 5 implants would be placed for a fixed prosthesis. The implants could not be placed more distally because there was no available bone. All the models were 3D printed and the entire surgery was simulated with our 3D printed models. As you can see, we had all the models with the implants placed in the proper horizontal and vertical positions, and based off of these models, all these surgical guides were printed for this patient. Here you can see we have the angulation guides, the depth guides, and the abutment multi-unit guides. This is the patient's panoramic right before the surgery. And here you can see we had everything prepared and ready to go the day of the surgery. We started with removing her prosthesis and placing the bone foundation guide. As you can see, all this excess bone above the guide was the bone that was planned to be removed to make sure that the implant prosthesis junction was not visible during her smile. Here's the video of the patient's surgery. And you can see we're removing all that bone. This bone was salvaged and used for grafting throughout her entire mouth. As you can see, this is the saw we used to remove the bone. And at the area where the largest bone was removed, it was a total of 6 millimeters. It wasn't uniform throughout. Here is the implant surgical guide placed. This is the implants placed. They were Straumann bone level implants. And the multi-units were placed on the implants. This is the tissue gasket that was placed. And the implant provisional was placed intraorally and picked up. The implant provisional was placed back on the model to ensure that the surgery was accurate. This is the patient's provisional after it was polished and placed intraorally, and the patient had a long-term fixed provisional in the maxilla, as you can see here. Then we moved on to the mandible during the same surgery, and all the hopeless anterior teeth were extracted and the molar was extracted. All the 3 implants were also explanted. This is the patient's mandibular provisional. The same procedure was done in the mandible, and you can see the multi-units are placed. The tissue was sutured, and the provisional was picked up. Here you can see the patient with her maxillary and mandibular provisional. The patient was quite happy with her smile. Right now we are in the process of getting back the patient's full maxillary fixed zirconia and mandibular zirconia prosthesis with anterior cutbacks in shade A1. The patient's family, her husband and daughter, were both involved with the tooth shade selection and the tooth shape selection. As you can see, it was very important for us to collect all the data to make a proper diagnosis and treatment plan for this patient. The patient is very happy with the results so far and is looking forward to receiving her final prosthesis soon. Thank you very much. And if you have any questions, please feel free to email me at drjulietdds@gmail.com. Thank you very much. I would like to thank the American College of Prosthodontists for hosting such a wonderful National Prosthodontics Awareness Week, and also for Columbia University College of Dental Medicine, where this case was done.